First, I am going to discuss today the insufflator. After that, I will discuss telescope, camera, light source, light cable. All the electronic part I am going to discuss today, except energy sources. Energy source we will discuss later. Energy source means monopolar, bipolar, harmonic, ligaseous, that I will demonstrate you later. The insufflator, the first thing when you go to buy the insufflator, first thing they will ask you that which capacity insufflator you want to buy. Insufflator is available in the market from 6 liter up to 45 liter capacity. So what is the meaning of 6 liter and what is the meaning of 45 liter insufflator, and which one you should buy? Any answer?
The fluid is per minute.
The pneumocollector only 6 liters.
445
Flow rate. Very good. Means 6 liter has only 6 liter per minute flow rate. And 45 liter has 45 liter per minute. So which one you should buy?
according to your need.
Depends on your surgery. Pediatrics.
Okay. So if you are performing, suppose you are a gynecologist and you want to do only the diagnostic laparoscopy, tubal patency test and simple surgery, ovarian drilling and all, then
6 liters.
yes, 6 liter insufflator will be sufficient. If you want to do some advanced surgery like TLH and all, then 18 liter insufflator you should buy. And if you want to do bariatric surgery or solid organ surgery like splenectomy or radical hysterectomy, in those situations you should buy little stronger insufflator, that is better to use 45 liter. Now my question is that why I need 45 liter? What is the meaning of 45 liter? You have, all of you have told that 45 liter insufflator means the flow rate is 45 liter per minute. But you have to correct this sentence little more. Flow rate is not 45 liter per minute. 45 liter insufflator means maximum flow rate is 45 liter per minute. Even if you have a 6 liter insufflator, you can do bariatric surgery. There is no problem in bariatric surgery. But you have to be extremely careful that any gas should not leak. Or when you are using the suction irrigation, you have to be careful that always dip your tip of the suction into the bladder and you don't suck any air. Because if your insufflator is 6 liter and if you are sucking at 8 liter, then abdominal wall will collapse. But if your insufflator capacity is 45 liter and then you are sucking at a rate of 8 liter, 10 liter, 20 liter, 30 liter, then also your insufflator will be able to compensate that loss of the gas and your abdominal cavity will be distended and you will have working space maintained. So this is the difference, that maximum flow rate. Just like if you have a sports car, that doesn't mean that if you will sit in that car automatically as soon as you will start it will go 350 km per hour. Maximum speed is 350 km per hour. But even that car you can drive at a rate of 5 km per hour. So maximum flow rate is 45 liter. This is first criteria when you buy the insufflator. Second criteria is that you should have choices of different type of insufflator. Some insufflators are analog, some insufflators are digital, and some insufflators are microprocessor controlled digital. Analog insufflator, this is an analog insufflator. This insufflator is a storage insufflator that is called by Laparoscopic, and it was a very popular insufflator once upon a time in 90s. It has Quadro manometric indicator, 1, 2, 3, 4. It has 4 indicators. And this is also automatic. This also takes care of your flow rate. And if the pressure desired 12 mm or 15 mm, whatever you will set, once the desired pressure is achieved, this also switch cut off automatically. This also doesn't have the problem, and this also gives you alarm, but it is analog. there is no microprocessor. It doesn't need electrical connection. It doesn't need any wire for, there is no any bulb, there is no any electrical connection. It works with the pressure of the cylinder itself. And there is a cut-off valve which works on the pressure. Just like if you have some experience of the ICU, the older ventilators of Siemens, it was working with the CO2, with the oxygen cylinder pressure only. You don't need any electrical connection into that. New generation ventilators are electronic. So exactly same way, it is a complete analog. There is no electronic part inside this. Now new generations are digital. In digital also microprocessor control. The advantage is it has a lot of rectification, it has a lot of alarm and a lot of auto correction also. Like one example I will give. Suppose this is a Veress needle and I have attached the Veress needle, and then after attaching the Veress needle I have seen that so I have pushed the Veress needle and I have attached it, and after attaching it I have seen I have attached the tubing, and then I am switching the insufflator on. Here this is insufflator and I will switch it on. You will see very typically that as soon as insufflator is attached, it will give you some error here. This is the mistake which we have done, and it will locked. I have to switch it off and switch on again. Here this is important, and you have introduced it in Chalo Lago. And you will see there that as soon as it is in, it will give you the error. Reason of this type of error is that Veress needle was introduced first. Why? Because right now there was air inside this tubing. And if I have attached the Veress needle and then I switch on the insufflator, then first what will go? Air. Just like if your nurse, if she will put the IV cannula and then she will attach the IV tubing in the IV cannula first, and then she will attach in the bottle, what will go first? Air. So she must flush the air out. How she is doing? First she is attaching the IV channel to the bottle and then bringing all the saline up to the tip, and then she is connecting to the cannula so that any bubble should not go into the vein. Exactly same way this insufflator has recognized that this is a wrong method of connecting the Veress needle, and that's why it is giving the error and all the buttons are locked. Now it will not switch on. If you press the switch on off, it will lock. So this is who is doing microprocessor inside. That will automatically recognize the wrong steps. So what you have to do, switch off again, disconnect it and switch it on now. And you will see here, the air coming. And all the air is flushed out. Amount of air from here up to there is 800 ml. And this 800 ml is discharged. Now up to the tip of this tubing, what is there? CO2. And now there is no error and it came to the standby position. Now this is ready for flow to start. And then you should attach with the Veress needle. So remember, don't connect the Veress needle with the tubing of the insufflator without switching on the insufflator. If you connect and then you will switch on the insufflator, if it is good microprocessor control insufflator, it will give you error and it will lock itself. And if it is cheaper quality, then it will put the air. And if this air enters into the vein, even 800 ml air is sufficient to kill the patient by air embolism. So this will be dangerous. Now it has 4 types of indicator. That is called as Quadro Manometric indicator. First indicator is called as preset pressure. Second indicator is called as actual pressure. Third indicator is called as flow rate. And fourth one is total amount of gas used. preset pressure, actual pressure, flow rate and total amount of gas used. This is called as Quadro manometric indicator. Quadro means 4, manometric means pressure indicator. Preset pressure, initially you should keep the preset pressure. Suppose you want to do thoracoscopy, then it should be 6. Generally in thoracoscopy, it is not good to put the gas inside the chest. It is not necessary. But if you have to put it, maximum 6 mm of mercury is required. If you are doing diagnostic laparoscopy under local anesthesia, then you should use 8 mm of mercury maximum pressure. Because your patient is not intubated. If you put more pressure, patient may feel discomfort because the diaphragm will be pushed up. Patient will feel suffocation. Patient cannot breathe. And there will be a lot of irritation of the soldier tip. If you are performing operative surgery under general anesthesia, then you can initially try to work on 12, and if you are feeling little difficulty, you can maximum go for 15. If you are performing some advanced surgery where a lot of omentum fat is there, like bariatric, the bariatric surgery, the female patient, there most of the fat is outside the body. But in the male is inside the abdomen, most of the fat is in the omentum. So due to that, vision is very much difficult. Reaching to that hiatus, reaching to the gastroesophageal junction is very difficult. In those situations, sometimes you may increase up to 18. But 18 is your last reading. After 18, if you will go, all the problem will be quadrupled. Even in the bariatric patient, if you will go after 18, then abdominal wall has so much fat that abdominal wall could not be lifted up. Vena cava will press more, and patient has all the problem quadrupled. What are the problems? Decrease in venous return, decrease in cardiac output, decrease in tidal volume, decrease in minute volume, decrease in renal perfusion, cerebral edema, hypercarbia, and then a lot of problem in the DVT and other all these which we have discussed during the advantage and disadvantage of minimal accessory. All the complications will be quadrupled, and rate of absorption also will be faster. So after 18, any laparoscopy is not recommended. Now if you are doing extraperitoneal surgery like TEP or retroperitoneoscopy, then you can go up to 22 also. Like totally extraperitoneal hernia surgery or retroperitoneoscopic nephrolithotomy or ureterolithotomy or nephrectomy, extraperitoneal, then up to 22 it is okay. Why? Our gas is not in the abdominal cavity. So it cannot press the vena cava and it cannot press the diaphragm. But remember, if you are doing any extraperitoneal surgery and accidentally peritoneum is pricked and then gas enters into the abdominal cavity, then immediately reduce it to 15. Because now no more you are allowed to continue at 22. You will be in trouble. So this is maximum limit for extraperitoneal. Now, if you are doing some closed pocket surgery, like if you want to do the axilloscopy for breast augmentation or saphenous vein surgery in the thigh or vascular surgery in the popliteal fossa, in those situations you can go up to 30. You are allowed to go up to 30. And that way you can consider, because it is not a pre-formed cavity. It's a artificial cavity which we are forcefully making, isn't it? So at 12 you will not have any space to work. So you can go up to 30 also. So this is preset pressure. What is the meaning of the preset pressure? Preset pressure is a command given by the surgeon to the insufflator to keep the pressure at that level. Like suppose this is abdominal cavity, and if I will start the flow starter. If I will start the flow, it is increasing. 8, 9, 10, 12. Now 12 came, then flow become 1 or 0. it will become 0, because now it is desired pressure is achieved. If I will press it from somewhere, like I am trying to press it here,
Actual pressure increase.
then see actual pressure is how much? Then it will give me alarm for 5 seconds, and after 5 seconds it will take the gas back. See, now it is taking back. So insufflator is not only pushing the gas, it takes the gas back also. And if pressure is released, again it will push the gas and will bring it to 12. So if the pressure is less, it will push the gas. If pressure is more, it will take the gas back. So preset pressure, I have given the command to this insufflator that please maintain it to 12. And it will try its best to maintain at the 12 according to its capacity. Suppose capacity is only 8 liters per minute and I am leaking at 20 liters per minute, then it cannot maintain the pressure. Isn't it? But if it is a 45 liter insufflator and if I am leaking at 30 liters per minute, then it will maintain the pressure. If I will go 50 or 60 liters per minute, then it will not compensate. Most of the time with the 5 mm suction, if you are sucking with the normal OT suction, that is 22 minus 22 Pascal pressure suction, then maximum suction of the gas is possible 30 to 40 liters. So even if you are, in spite of doing a lot of use of suction, your working space will be maintained. And that's why high capacity insufflators are better. Now, question is, why immediately it has not taken the gas back? When the pressure was there, after 5 seconds it is giving alarm and it is waiting again 5 seconds and then it is taking the gas back now. Why? Why it didn't do immediately? Reason is, whenever you are putting your secondary trocars, always pressure is increased. Suppose my telescope is there and I am putting one trocar here. So due to that pressure of the trocar, the pressure will increase. And if the insufflator will suddenly take the gas back, then that trocar can hit the cecum or it can hit the bottle. So it will give you 5 second time. Up to 5 seconds, there will be no alarm also. But as soon as you start hearing the alarm, you should stop and do the second attempt. Then again it will give you 5 second time. If you are listening the alarm, don't continue. Alarm means your time is over. And if you will do it again, then it will take the gas out. In spite of listening the alarm, you are pushing, it will take all the gas out and abdomen will deflate. So if you are listening the alarm like this is my time and my trocar should be in. And if alarm is there, I will stop and I will do second attempt. If second attempt also within 5 seconds I could not enter into the abdomen, then I should take third attempt. But alarm means you should stop. In spite of listening alarm, if you are pushing, then it is danger. There may be injury to the bowel. So this is the microprocessor which is taking care of this. Now, there are two types of flow. This is flow rate. One is Veress needle mode, another is cannula mode. When you use Veress needle, then you will put to the Veress needle mode and you will attach the Veress needle. And then you start the flow. Once you will start the Veress needle mode, it will become pulsatile. This is pulsatile flow. Now listen this. It's not continuous. Veress needle mode is always pulsatile mode. And it is preferred mode. Because at pulsatile mode, it wants to synchronize with the diaphragmatic movement. When the anesthetist is inflating the diaphragm, at that time it stops. And once the gas comes out, diaphragm is getting upper, then it puts the gas. And it wants to synchronize with the and slow insufflation is always better because patient has time to get acclimatized with the increasing pressure and there will be no vasovagal shock. Second advantage is that whenever you use the Veress needle, there is some error here. You can see sometimes 0 flow on. Here you can see sometimes 0, sometimes 17, sometimes 8, sometimes 3, sometimes 16, sometimes 0. So what is the actual pressure? Actual pressure is varying, and that is one of the reasons sometimes the gynecologist or surgeon become panic that they are going somewhere wrong and they take their Veress needle out. Although it was in the abdominal cavity. But after seeing these fluctuations in the actual pressure, they become panic and they think that they are in some wrong place. And why this increasing reading is giving? Because of the resistance of the eye of the Veress needle. If I will remove the Veress needle, it will become 0. There is no any error. Why it is 0? No pressure. Because it is going in 0 cavity. And suppose if I am in abdominal cavity, initially it will remain 0 and then it will rise slowly. 2, 4, 8, 6. Can you see that?
Yes.
It's rising. There is no error. But as soon as you attach with the Veress needle, this error will come. Sometimes 16, sometimes 18, sometimes 20. Then it's very bad. How can I know that where it is? So if you are using Veress needle, then actual pressure is when it is off. When the gas is going, at that time it is a false pressure. When the gas is not going, at that time it is a true pressure, which is sensed by the insufflator. So the actual pressure is minimum of 5 reading. And what is the minimum here? 0. Can you see that?
Yes, sir.
Minimum is 0. So always remember, if you are putting the Veress needle and there is a lot of fluctuation in your insufflator, then the upper reading should be ignored. You have to only take care of the lower reading. And minimum of the 5 reading is the actual pressure with the Veress needle. With the cannula, this error will not come. But with the Veress needle, this error is coming. Why? Yes, due to the resistance of the gas flow through the small eye of the Veress needle. So this principle you should understand how it works. And here now you can see minimum is 0. But once little pressure will form, then this 0 will not come. Now you will see any time this 0 is not going to come now. It will be 1 or 2 or more. Now 0 is not there. Why? It is little distant. Isn't it? So what is the actual pressure now? 4. You should ignore 24. Don't get panicked with the 24. You should see the minimum. With the cannula mode, this problem is not. Now, when you attach the cannula, suppose this is the cannula, and I will attach the cannula. After attaching the cannula, you cannot work with the 1 liter per minute. Why we are using 1 liter per minute with the Veress needle? Here embolism should not occur. Yes, because directly if our Veress needle is going into any vein also, as long as your flow rate is 1 liter per minute, patient can tolerate. Patient can tolerate that much gas, and this gas can be washed out. 1 liter per minute can be washed out with our respiratory system. There will be no any air involved. Because CO2 is 200 times more absorbable than oxygen and 20 times more absorbable than room air. So as soon as it enters into the vein, it gets absorbed. But if you have a cannula, suppose this is cannula, now it is not possible to work with the 1 liter per minute. Do you know why? Because I have to use the instrument, I have to use many instruments, 3-4 cannulas are there. And suppose this is distended now, it is distending, and suddenly it is collapsed, then again I have to wait a lot of time to get it distended. So in the cannula mode, you will switch it to the 0 to max. Now it is 0 to max. Means this is cannula mode. And now the insufflator is ready to push the gas according to demand. according to requirement. Now it is no more 1 liter. So right now flow is 0. Can you see that? But now I am leaking. Now flow is 5. Let me put directly, then you can appreciate the sound better. So right now it is 0. Now more. 2, 3, 4, 5. Increase it. And if I will close it, it will stop. And if pressure is achieved, it is 0. And if pressure is more, it will take the gas back. So insufflator automatically will decide. None of the insufflator of the world is manual. Automatically it will decide. If it is manual, it is dangerous. Because if I will set the 8 liter per minute, abdomen may burst. So insufflators are always sensitive to pressure. They are automatically sensitive to pressure. As soon as pressure is achieved, it will stop. And once the pressure is less, it will start flowing. And the rate of flow will be decided by the rate of loss. If the rate of leak is 20 liter per minute, the rate of flow will be 20 liter per minute. And vice versa. And this way you can adjust the flow rate. So now sometime what happens, and now sometime what happens, that when you are using the insufflator, in a starch insufflator, there is no automatic 0 to max or 0 to 1. They have manual adjustments. If you have seen there is a bar, longitudinal light, and there is plus minus. Once you press plus, light is switching on up. And on the side of this light it is written 2, 4, 8, 10, 20, 30, 40. And manually you have to adjust. That what should be the flow rate. Here there is no manual adjustment. It is automatic. So which one is good? This is good or that one is good? This is good? That is good. Reason why I am telling you. Remember, this manually what you are adjusting. In a starch, when you increase the flow rate, what you are adjusting is not the flow rate. You are adjusting the maximum flow rate. If you are adjusting to 8, that means you are adjusting maximum flow rate to 8. If you are adjusting to 8, that means flow rate will not be 8. It will be maximum 8. There is none of the insufflator in the world which is manual. All are automatic. And the advantage of fixing the maximum flow rate to less is that your complication will decrease. Here, I cannot manually adjust the flow. It is fully automatic. And maximum flow rate will be decided by the amount of leak. Suppose I am doing surgery and one of my cannula is open and gas is leaking. I cannot listen this sound in the noisy operation theatre. And at the end of the surgery, when I see here, I came to know that I have lost the 40 liter of the gas, or I have lost the 100 liter of the CO2. Now, losing a lot of CO2, what are the disadvantages of losing a lot of CO2? First disadvantage is economical. I am losing the gas, money. Second disadvantage is that there is a chances of hypothermia. Patient was prone to develop hypothermia. If patient has not developed, thanks to God. Isn't it? And third disadvantage is dryness of intestine. So in those type of insufflator which is manually adjusted, initially for the Veress needle you should adjust it to flow rate 1 liter per minute. After that, once you put the cannula, then you adjust to the medium flow, that is 6 liter per minute. So that if the leak is more than 6 liter per minute, abdominal wall will deflate, abdominal wall will drop down, and it will draw your attention. You will come to know that what was the problem, where I am wrong. And that way it can draw your attention. And then you will do the corrective measure. What are the corrective measures? If a skin wound was big, I will give one stitch. If there was some problem with the valve, I will change the valve. If I have forget to put the reducer, I am using a 10 mm port with the 5 mm instrument without reducer, and abdominal valve is deflated, then immediately it will draw my attention and I will put the reducer, so that unnecessarily leak I can stop. It is just like a cruise control of the car. In the car you have cruise control. So cruise control, if you will set to the 60, then if your driver will press the pedal also, accelerator also, car will not go more than 60. So upper limit is 60. So manual temperature insufflator, what is there, that maximum flow rate is that much. If you setting to the 6, doesn't mean that flow rate started 6. Maximum is 6, after 6 it cannot go more than that. But that is also automatic. So that's why manual adjusting insufflators are better. But remember, if you have a manually adjusted insufflator, and if it was at 6, and if bleeding has started somewhere, massive bleeding has started, you should not do the study on the 6. You should immediately tell your nurse to go and put to the high flow. Just like if someone is coming to kidnap you from the other car behind, you will not keep the cruise control of your car on. You should remove it, because it is life and death. Your driver should run the car as much as possible. It is emergency. In emergency, cruise control is not recommended. Here it is always ready for emergency. But that one you have to adjust for emergency, normal and Veress. So it has 3 modes: low flow, medium flow, high flow. During Veress we will keep low flow, during surgery keep medium flow, and in emergency keep high flow. But remember, high flow, even from beginning if you will keep, no problem. Because high flow doesn't mean it will flow high. High flow means it is ready for high. Even if you will put it to 45 liters per minute and there was no gas leak, insufflator will remain 0. This is very important to keep in mind. That insufflator you cannot force to put the gas. Now the next indicator. Next indicator is total amount of gas used. Total amount of gas used to reach to the preset pressure. Total amount of gas used to reach to the preset pressure of 12. Preset pressure of 12 is minimum 1.5 and maximum 6. Before putting the first trocar, our actual pressure should reach to the preset pressure, isn't it? And at 12 millimeter preset pressure, minimum amount of gas required is minimum 1.5 and maximum 6. What are the variables? One is the height and the size of the patient. One patient is only 4 feet tall, another patient is 6.5 feet tall. So, of course, the taller patient will take more gas. Another variable is muscle relaxant. One patient you are doing under epidural or spinal anesthesia or local anesthesia, then you cannot give muscle relaxant. Patient is tight. So, with the less gas only, 12 millimeter mercury pressure will achieve. Another patient, nice muscle relaxant, general anesthesia, then 3-4 liter gas will be possible to introduce to get the same pressure, 12. So that's why GA is better, because more gas means we are more safe. Because more gas means the space between the bowel and abdominal wall is more. And then our first trocar is easily and safely introduced inside. Third variable is bowel preparation. One patient you have started preparing the bowel 2-3 days before, especially when you have to do the colorectal procedure, then at least 1 week before many surgeons they start bowel preparation. giving the fiber-free diet. And 2 days before the surgery, they start giving peglet powder, that is polyethylene glycol. As a gynecologist also, if you have to do total laparoscopic hysterectomy or myoectomy, prior to the night of the surgery, polyethylene glycol should be given, 1 or 2 sachets with the clear liquid, so that if the bowel is nicely prepared, you can put more gas, and there will be no distended bowel. Next variable is anesthetic agent which you are using. If you are using nitrous oxide as anesthesia, then there will be some problem that nitrous oxide always distends some gas, and that gas is escaped into the free cavity. So nitrous will distend the bowel, and then your working space will be reduced. But if you are using isoflurane or sevoflurane, then they don't distend the bowel, and if bowel is not distended, you can put more gas. Next variable is any space occupying lesion or any fluid in the peritoneal cavity. Like suppose rupture ectopic, already 2 liter gas, blood was already there. Then I can no more put more CO2. Or if there was a huge dermoid cyst or ovarian cyst, then also CO2 cannot be introduced more. So we should develop this intuition that once you come to the OT and your patient is lying on the table, and just by palpating the patient abdomen and seeing the size of the patient abdominal cavity, and then knowing the muscle relaxant and bowel position, you should be able to decide that how much gas this patient needs. Like if you will do the surgery for bubbles, you need only 1.5 liter gas. But if you will do a surgery of a 70-year-old grand multi-para female, then she may take 6 liter. Because after multiple delivery, abdominal wall is lax. In those situations, a big size, and then it will take more gas. So this is very important to judge that total amount of gas. But remember, this variable of 1.5 to 6 I have given for preset pressure 12. If I will increase this preset pressure to 18, then this will increase. Because now gas is more compressed. Isn't it? If I will increase this to 18, then it will become minimum 3 and maximum 9. Why I am telling you this? Because in some surgeries, SAGES guideline, some book, the amount of the gas which is required to, before putting the first required, is written 3 to 9 or 3 to 10. Why? Because this limit they have kept it to 18. Is it clear? So if I will put this preset pressure to 100, then it can take 20 liter gas also. It will be compressed, but abdominal wall will burst. Because 100 ml, 100 millimeter of mercury anyway cannot be introduced into the abdomen. So this is total amount of gas used. Now question is, how much is the total amount of gas used? Before putting, is the first trocar was 1.5 to 6. Now how much is used during 1 hour of the surgery? During 1 hour of the surgery, the minimum is 18 liter of the gas. That means you are a good surgeon. 1 hour of the surgery, if you have used up to 18 liter, that means it was okay, it is tolerable. But at the end of 1 hour, if you have used 50 liter, if you have used 100 liter, that means you are not a good surgeon. That means, what are the possibilities? All the skin wound is bigger. Another possibility, all your cannulas are old, broken. Your valves are broken. And your technique is also wrong. That unnecessarily you have sucked a lot of gas. You are sucking less blood, more gas. And your technique is wrong, that you have not used proper reducer. You are not knowing how to pull the reducer out with the instrument. You are taking the instrument first and then taking the reducer out. Isn't it? And all these techniques will lose a lot of gas. Now question is, the gas which is leaking outside, is it bad for our body? CO2 which is escaping outside the environment is not poisonous gas. CO2, remember, CO2 is a healthy gas. CO2 is not an indicator of pollution. carbon monoxide, sulfur dioxide, these are polluted gas. CO2 of course doesn't support the human life, but it doesn't kill the human life also. The amount of CO2 which is in our environment right now, even if it becomes 10 times more, then also we will not die. And CO2 is necessary for plant. CO2 is necessary for anaerobic bacteria. So CO2 is not a problem. But unfortunately, many of the small city, their supply is industrial CO2. And industrial CO2 is not good for surgeon's health. Do you know where the industrial CO2 is maximum used? Maximum industrial CO2 is used in your beverage industry, cold drink industry, soda, Pepsi. One bottle of the Pepsi has 500 means half liter CO2. It is compressed CO2. So and that's why once you drink it, a lot of CO2 comes out from our mouth. We have the regurgitation. But those cold drink industry is not in every city. It is at some places in country. Every city is not making. In every city, the maximum consumption is the fabricators and bakery industry. You know how they make the bread? Yes, the bread, what they do that on the floor, they put the wheat and water, and with the leg they mix wheat with the water, wheat dust with the water. Of course, they wear one rubber boot so that the dirt of the foot should not go, and with the foot they mix the leg with the water. After that, they put the yeast over, yeast, fungus, and then they spray the CO2. Not with this cylinder, they have separate machine to spray the CO2. And once the yeast will have the CO2, then they started fertilizing and growing because those are anaerobic. And after that, they vomit and defecate. They eat them, and then they go into the holes of the bread. That is called as fermentation. And they vomit and defecate. So each hole of the bread is one toilet of yeast. Actually, the hole in the bread which you are seeing, all holes are one toilet of the family of the colony of the yeast. And that you are eating. Of course, it is a good source of vitamin B12. It's a very good source. But it is how they make it. So those industrial CO2 should be cheaper in the cost. Cheaper in the cost. And those industrial CO2, they are making crude way by burning the different type of waste material. So in that CO2, there is a dust also, there is carbon monoxide also, there is sulfur dioxide also, of course less concentration, but these impurities are there. So it is our job that if the CO2 vendor is giving you the CO2, you must see and you should try to check that it is a medical grade CO2 or industrial CO2. If it is an industrial CO2 they have given you, because once you ask them for the CO2, they think that it is something not life-saving. It is not oxygen. CO2 may be some other purpose. So they give industrial CO2 because it is a huge, if this cylinder, if you will get industrial CO2, it will cost you only 50 rupees. But if you will get a medical grade CO2, it will cost you 300 to 400 rupees to get it filled. So of course anybody wants profit. So they will tell you that it is a medical grade, but for them to get a good profit, they give you the industrial CO2. So this industrial CO2 is bad. So leaking is bad for us also. For patient it is not very bad because patient is exposed only one time. And we are exposed every day. So that has a carcinogenic effect. And because once the interior milieu is maintained, inside of environment is cut off from outside. So at the end of the surgery, when you are pulling the cannula and emptying the abdominal cavity, then a lot of that CO2 with the burned tissue, viral DNA, bacteria and carcinogenic substances are coming out, and if you are inhaling it, it is bad for you. So that's why it should be avoided. And medical grade CO2. What to avoid? Leaking should be avoided. You should not do leaking. That's why many of the time here, once we do the animal dissection, generally we don't use CO2, we use air, room air. because at the end of the procedure it will be anyway sacrificed. It has to be sacrificed by law. It should not be left. In anesthesia only we give little more anesthesia and it will be sacrificed. Otherwise it will be pain once it will be recovered. And it is called as euthanasia. Means in anesthesia only it should be end of the death, of the end of the life. So air we are using because CO2 environment everywhere is not good. So another important thing that when you use a cylinder, don't keep the cylinder lying down. Always keep the cylinder erect up. Because if you put it lying down position, liquid CO2 enters. You know, in the insufflator, once you buy, they give you the cylinder. And the first cylinder which comes with the insufflator is 2 kg cylinder. This is the first cylinder which they will give you, that is 2 kg cylinder. And this 2 kg cylinder can take 22 Pascal at pressure, 22 kg CO2. Isn't it? So if you are very careful, you can, 22 liter, the 2 kg cylinder. So you can perform 1 or 2 surgery if you are careful. If you are not careful, in the half of the surgery, it will be empty. So it is used by freelancers. Sometimes they keep 2-3 these type of cylinder in their car and they go from one hospital to another. If you want, if your hospital has central line supply, then already CO2 is coming. Otherwise you can use bigger cylinders so that in one cylinder at least 4, 5, 6 surgery can be performed depending upon how much you are wasting. So if you are keeping it lying down position, then here also if you will see the connection is like that it is erect. It is not lying down, it is erect. Because if it is erect, then the CO2 will come first and liquid will be down. Not only that, after repeated filling of the CO2, some water enters into the cylinder because of the humidification. And that water, if it is lying down position, if water enters into your insufflator will get spoiled. So that's why it should be avoided. Now the question is that how I will know that this insufflator is working correctly or not. Time to time you have to calibrate it. And calibration is very easy. What you do, take the tubing and connect with the BP instrument, a sphygmomanometer. This tubing from the sphygmomanometer. This is the cuff of the instrument with the dial. And then switch it on. Automatically it will give you millimeter of mercury. Because this is also millimeter of mercury, that is also millimeter of mercury. And that way you can calibrate it. It is very easy. Another question is, what to do if accidentally in the half of the surgery, my insufflator becomes empty. Yes, gas is empty. Then what to do? In those situations, you can use one BP cuff. This is a BP cuff. And clean the tip of this tubing with the betadine and then attach it into the cannula. And after that, suppose this is inside the abdomen of the patient, you will ask your assistant to pump with the air. And with this air also, you can continue your surgery. She is pumping and abdominal cavity will inflate. Of course it is air. So, it is little risk. But remember, once you have already started the surgery, it is not much. Because maximum risk is during the entry. And if you keep the pressure less than 12, then there will be no air embolism. Unless until you are doing vigorous dissection, high pressure and any open venous sinus are there. Otherwise it will not have a problem. Now question is, when she is pushing, how I will know it is 12 or 18? That is very easy. You connect this tubing of the insufflator with the another cannula. And then it will give you pressure, because this pressure will go like this. Can you see that? This pressure. Because if I will put this both of them, it is attached with the other cannula, then automatically it will give you the real pressure. See, once it is pushing, pump karo, it is also increasing. Did you see that? So you can attach this tubing to the other cannula and it will give you, see, it is increasing now here. And that way you can control, she can control. because she can see that how much is the pressure. Now she is pumping and the pressure is increasing. 2, 4, 6, 7, 8, 9, 10, 12, and now she will stop. Isn't it? So that way she can control it. Sometimes some people they use nebulizer, push the air. And some air insufflators are available in the market. This is air insufflator. This is air insufflator. This is a small insufflator, very cheap insufflator. It will cost you only 20-25,000, and this is air insufflator. This insufflator will take the room air. But remember, medical legally use of this is wrong. If someone asks you who has told you, don't take my name. But it is medical legally wrong. If something goes wrong, it is negligence. So you should never start with the air. Don't make it a habit. It should be only suppose 90% of the cholecystectomy is done and cylinder is empty now. In those situations, why to convert? In those situations, use room air. And it is not like that in room air you cannot use energy. Energy you can use. Just like in open surgery, you are using Quadro or not. You are using. So using air energy is not a problem. Using nitrous energy is a problem. If you are using nitrous, you cannot use bipolar or monopolar. But air, it is okay. You can use it. So this way, you have to decide the insufflation. Calibration, there are two ways. One way is if you have a dial type of BP instrument, then directly you will attach the tubing and the dial type of BP instrument, the pressure, it will show you exactly the pressure how much. Another way is if you have a mercury column insufflator BP instrument, then you put it like that and tie a knot here. Knot here. After that, you wrap the BP cuff around this. And then start the gas and bring it up to the zero level of the column. Here also zero and BP mercury is also zero. And after that, start the flow and bring it to 30. Once you bring it to the 30, mercury column of the BP instrument should go to the 30. That means it is correct. If here it is showing 30 and mercury column it is showing 50, that means it has to be calibrated. It is dangerous. It can create big problem. One of the major reasons why insufflator becomes easily spoiled, because sometimes the fluid enters from this channel. If you are doing hysterectomy, in LFVH there are two parts. One is laparoscopic, other is vaginal part. In laparoscopic part, once you have finished, then you have to remove the instrument, deflate the abdomen, but cannula will be there. Because after finishing the vaginal part, again you have to come back to have the final inspection. So at that time, sometimes we forget, insufflator is switched off, but we forget to disconnect this tubing. And then once the cannula is touching the bowel, then some blood comes and it enters into the insufflator. Even if the 2 ml blood or the fluid from the abdominal cavity, if it enters into the insufflator, there is one sensor and diaphragm, immediately it gets spoiled. So this is a small precaution has to be taken. You should that's why in many of the insufflator it is a good practice to start one filter here. There is one filter at this point also in the insufflator, it is good to attach. That will not allow the fluid from outside to enter, and it stops and filters the dust particle and some other which is common. Remember, from the CO2 cylinder, bacteria can never come. Even if it is industrial CO2, bacteria will never come. Why? It is such a huge pressure that CO2 is converted into liquid. It is no more gas CO2. And in that liquid pressure, no bacteria can survive. It becomes sterilized its own. You don't have to worry about that. And CO2 anyway doesn't allow any aerobic bacteria to survive. And at 22 Pascal pressure, all the gas CO2 converts into liquid CO2. So now I will ask you few questions. And if you will answer those questions, that means you have understood the insufflator nicely. Question number first. Preset pressure is?
The desired pressure.
Preset pressure is 12. Preset pressure is 12. Actual pressure is 6. Flow rate is 1 liter per minute. and total amount of gas used is 8 liter with the Veress needle in a 22-year-old nulliparous woman. Then where the gas is going? Again question. Preset pressure is 12, actual pressure is 6, flow rate is 1 liter per minute, total amount of gas used is 8 liter per minute in a female of 22-year nulliparous woman. If you are doing with a Veress needle and there is no abdominal distension, then where the gas has gone?
From the source of the Venakawa.
Okay, you are saying that it is leaking somewhere in the chest. Okay. Then?
Venakawa.
This is Venakawa. Yes, he is correct. Any other answer? In the bowel. Other answer? Sweet patterns. These all are incorrect. Only correct. Why incorrect? I will tell you. Only correct is Venakawa. Do you know why it is not leaking?
Actual pressure is 6.
Yes, if you will leak anywhere, it is a very simple mode, versatile mode. So minimum of the 5 reading will come 0. If it is leaking in outer atmospheric environment, because outer atmospheric environment pressure is 0. Is it clear? The pressure of the vena cava is 6. Why it is not in pre-peritoneum? Because if maximum capacity of abdominal cavity itself is 6, that how come in any abnormal cavity it can go to 8 and still the pressure is 6 only? Is it possible to put a 8 liter gas, 8 liter means box in a 3 liter box? You cannot do that. So is it possible to put 8 liter gas in pre-peritoneum, which is inside the abdominal cavity, and still the pressure is 6 only? It is not possible. Exactly same is true for bottom. Yes.
Sometimes we extract the air in the beginning of the operation, and we didn't reset the machine.
So that is technical problem. That is
Yes,
that maybe that you are that way you are correct. But then also the minimum of the pressure will not be 6. Isn't it? Now next question.
And there be other sign and symptom as well.
Pardon?
May lead to air embarrassment.
No. It will not lead to air embolism. Remember, as long as your flow rate is 1 liter per minute, even if you put 100 liter gas in our body, there will be no air embolism. Because our body has a capacity. Do you know, during the huge, extensive sexual activities and marathon exercises, our body itself is producing 200 ml CO2 per minute. And if 200 CO2 per minute we are expelling out, 200 ml CO2 per minute is produced by our body. So you can understand, if 1 minute 200 ml, then in 1 hour how much? 60 into 200. How much? 1.2 liter. 1.2 liter anyway is produced by our body itself. So it is, if you will put 1.5 liter, 1 liter per minute, then it is beyond the capacity of our body to wash out. That is that much. That's why CO2 is used. Because by the time CO2 reaches to the heart, it is no more in air bubble. It disintegrated into the small microparticles that cannot do the blocking. That is one of the reasons why we use CO2. But as soon as this rate of flow, you know, even if you are using flow rate at 1 liter per minute, actually effective entry is only 500 ml per minute. Do you know why? It is versatile flow. Stop. Stop. So we are setting here 1. But actually if you will see, effective flow is only 500 ml per minute. So it is not a problem of air embolism. Now next question. Preset pressure is 12. Actual pressure is 12. Flow rate is 0.5 liter per minute, half liter per minute. And total amount of gas used is only 500 ml. Yes. Now it is pre-peritoneum. just like these gloves, within 200 to 300 ml peritoneal cavity, that pre-peritoneal membrane stretches out because it is attached with the abdominal muscles and the posterior rectus with the fibrous trabecules. So by default it is not a potential cavity. You have to break those fibrous trabecules and just like this glove, it will stretch. But as soon as it is stretched, immediately preset pressure will reach to the 12. Actual pressure will reach to the preset pressure. And still little flow is there. Why? Actually it is detaching by the side. Yes. So maximum capacity of the pre-peritoneal pocket to take the gas is 1 liter maximum at 12 millimeter of mercury pressure. Once you will put 1 liter gas into the pre-peritoneal space, after that flow will stop. It will become 0. Because now no further stretch of the peritoneum and detachment of the peritoneum is possible. No, it has a limit, isn't it? Because as soon as the 12 will reach, insufflator will stop the flow. And it is maximally stretched. Just like this gloves. I will show you. Start the flow. And it is how much? 12. And it is stopped. But remember, if I will hold this glove like this, even for 2 days, gloves will remain this way. See this glove. Beautiful wrinkles you can see here. Can you see those wrinkles?
Yes,
It can bend beautifully. Now I will show you what happens if I will increase the pressure. Now it will start this figure. See? This will rust now. So at 12 millimeter of mercury pressure, peritoneum gets stretched, but it cannot puncture. And maximum capacity will be only 1 liter. After one, just like here, maximum capacity was 200 ml. And after that, gloves was okay. It was not deformed, but now it is deformed. So this should not happen. So you should use the 12 millimeter. Come, 12 come. Once you will put the 12, it will start giving alarm. Why it will give alarm? Because the pressure is more. And then I have to release it. See, after 5 to 6 seconds, and then I am taking it out. And if it is at 12, it will not deform. So that's why 12 and 15 is the better pressure for peritoneal cavity. Now, next question. Preset pressure is 12. Actual pressure is 12. Flow rate is 0. And total amount of gas used is 200 ml. Then where the gas is going?
Small bowel.
It's not a small bowel. It is not in a small bowel. Again, preset pressure 12, actual pressure 12, flow rate is 0, and total amount of gas is only 200 ml. Yes, bladder, no bladder. It is subcutaneous or in the muscle above the rectus. It is not in the peritoneum also, above the rectus. Bowel I will come. In bowel I will reach. That is also a question. So if it goes to the muscle septa or in the subcutaneous fat in obese patient, after 200 ml flow will stop. It will not keep on little flowing because those are not stretchable like the gloves or like the peritoneum. So there is a limit. After 200 ml it stops. Next question. Preset pressure is 12. Actual pressure is 30. 30. Preset pressure is 12. Actual pressure is 30. Flow rate is 0. And total amount of gas used is 200 ml. Then where are we? The kink. It is blocked. It is somewhere blocked. Blocked. Total amount 200 ml, 300 ml. And there is only one setting. There is only one setting where preset pressure can go beyond the actual pressure can go beyond the preset pressure, and that is blocked. I will show you. See, I am switching off this insufflator and then switching it on. Now insufflator has removed all the circuit. Circuit was drained. Now it will go to the standby. It is standby. And your last reading it will remember. That is 12. Now I have started. And I start the flow now. Flow is started. What is the actual pressure? 12. Preset pressure? 12. But actual pressure is not going beyond the 12. Flow rate is 0. But I will kink it. And as soon as I will kink this tubing, within 3 seconds this insufflator will give alarm. Now it starts. कितना pressure? No, you 12. Off तो नहीं किया. Flow rate. देखो ये tight लगा हुआ है. It should be fully tight. There should not be any leak. So now I am kinking it. And as you will see now, it was loose there. 36, 35, can you see? And now it is alarm. But as soon as I will leave it, alarm will go. Again I will give some blockage somewhere. Now this is the blockage. After 3 seconds, it will give you alarm. And it will go, actual pressure is high. Can you see that?
Yes.
Why it is happening? Tell me, right now also gas is not flowing.
Because the sensor is on the tip.
No, sensor is not at the tip. Sensor is not at the tip, but it behaves like a sensor. How? Insufflator always talks with the cavity. It is giving pulses. How insufflator senses this cavity? That it gives waves. And if there is any cavity, that wave is absorbed. And then it will learn that there is some chamber. But if I will bend the tubing like that, that wave which is coming will be reflected back. And insufflator immediately recognizes that there is some obstruction, I don't have cavity. But still the gas is not flowing, but it will recognize. So where can we block? Veress needle block. Sometimes there may be block in the Veress needle. Veress needle was not cleaned properly. Or sometimes the on the floor inside your wire. And now suppose the valve of the Veress needle was blocked. It was blocked. Or suppose tip of the Veress needle is touching some bobble or momentum. Like suppose this is Veress needle and it was attached, and now accidentally you have closed it here. Now it will give alarm. Can you see? It is how much? 38. If it is little leaking also, it will not give alarm. But if it is not leaking, there will be alarm. Sometimes this eye of the Veress needle here is touching somewhere. Like this is the eye, and eye is touching like that. See, actual pressure will increase. You see that? So this is the problem. Or nurse is resting over the abdomen. Then also can happen. And in those situations, wherever actual pressure rises beyond the preset pressure, you should immediately understand that there is some block somewhere. Otherwise, even if you put in axilla or the thigh, it will not go above the preset pressure. If any chamber is available, it will not go above the preset pressure. Now next question. Preset pressure is 12, actual pressure is 12, flow rate is 0.5 liter per minute, total amount of gas used is 1 liter, and there is a unilateral distension. Then where the gas is going?
Partial, puncture.
Preset pressure is 12, actual pressure is also 12, flow rate is 0.5 liter per minute, there is a 1 liter gas has gone, and there is a unilateral distension. Then it is bowel. Remember, bowel will not get full with the 200 ml gas. Bowel can take a lot of gas. But after 500 to 1 liter gas, a coil of intestine will balloon up like a valvulus and will distend to one side. And other side you will have dull, and this side you have tympanic. That means my Veress needle was inside the bowel. Now which bowel is taken, that is also possible to make it up. If it is suprapubic bulge, that means bladder, left side sigmoid colon, right side cecum or a small intestine, and epigastric is either pneumo-omentum or a stomach. So that way you can make it out that where it is distending. So now the question is, these are abnormal settings. And you know, these questions are very important, which you have to keep remembered. And this insufflator is such a beautiful instrument that within few seconds only it will let you know where the gas is going. Now question is, these are the settings which we will get if there is a abnormal places gas is going. How I will know that gas is going in correct place? You know, if gas is going into the correct place, then the graph in between the actual pressure and total amount of gas used goes completely parallel. It doesn't converge and doesn't diverge. Like, let us take an example of an 18-year-old man who is going gym every day, and a six-pack abdomen and very tight abdomen, and he comes to you. Within 100 ml, 200 ml, liver dullness will get obliterated. Within 300, 400, actual pressure will come 1, 2. After 6, 700, it will come 4, 5. After 800 ml, it will come 6, 7. After 1 liter, 9, 10. And after 1.5 liter, 12. I am not talking about a very long person. Average Indian height 5 feet 4 inch, but very tight abdominal wall. Another patient comes, 70-year-old grand multipara woman. In that, also within 100 ml, liver dullness obliterates. There also, because this is the potential space. Always gas reach first to this space. That's why in perforation you are doing the X-ray erect posture. So it will be up. But within 600 to 800 ml, pressure will reach to 1, 2. After 1 liter it will come to 3, 4. After 2 liter it will come to 6, 7. After 3 liter it will come to 10, 11. After 4 liter it will come to 12. But from the beginning your graph is going parallel. This is what? Actual pressure, and this is what? Total amount of gas used. So this graph of the actual pressure and total amount of gas used, within 5 seconds it will let you know where the gas is going. If I am going to the correct place, slow rise in the actual pressure and slow rise in total amount of gas used. If I am going pre-peritoneum, within 200 to 300 ml, it will become 12. Isn't it? So I should immediately know, and I should take the Veress review out and put it again. If it is blocked, immediately it rises more than the preset pressure. And it started giving alarm. Is clear? Even in the bowel, you will get all over dullness, one-sided tympanic and unilateral distension. If it is in vena cava, then it will be dangerous. Your patient tachycardia also increases due to bleeding, and pressure is not rising. And if you have done a nicely suction irrigation hanging drop test, then during irrigation itself you will know that the blood was coming. But if you didn't do that, then it can start with the gas. So this is called as Quadro manometric indicator. This is a beautiful machine which can immediately let you know that where your gas is going. Some people what they do, that once they put the Veress needle, then they immediately don't start the flow. First your insufflator is switched on. Then they put the Veress needle, and then they attach the tubing, or they keep the attached tubing to put the Veress needle. So that inside is a negative pressure. I will show you. No, on cutting the see the negative was coming. Can you see that? Okay, negative. So without starting the flow, if you see -1, -2, that means you are in the abdominal cavity. Because by default, abdominal cavity has a negative pressure. And then once you see -2, -3, and you confirm, then you start the flow. So some people, they go in the attached condition also. But in our opinion, it is not good. What you should do, you go and do hanging drop, suction irrigation. Hanging drop is better. And then you attach it. And then you start the flow. Because hanging drop test or piston test or plunger test gives you better than this negative. Because sometimes this negative pressure can be achieved just by rubbing your finger over the, I will show you. Within few seconds it will give you negative pressure. I am just rubbing over this and it will give you. Sometimes it doesn't give, but many times it gives. So that's why it is always better to use your own suction irrigation and hanging drop test. So this was regarding the insufflator. Do you have any other question? Yes?
Doctor, when we insert the glass needle, sometimes we have variation in the pressure, high pressure, and there is no flow. So what you can do in this situation?
Where is high pressure? Where is no flow?
And sometimes when you insert the brass needle inside the abdomen, the cavity,
Yes.
there could be variation, wrong calculation or wrong pressure. Will be high. There was no flow. There will be no flow. Right?
If minimum of the 5 reading is high or always it is high.
It's coming up and down. 4, 24.
So then there is no problem.
But there will be no flow, right?
How you know there is no flow? This flow, this is coming 0. See, it is minus. Just after rubbing it becomes minus. Can you see that? So that's why it is not a very good indicator to keep in mind. You should always try to do hanging drop test. You know what I was telling you? That if there is no flow, 0 here, and it is high, that means you are in wrong place. Either the tip of the Veress is touching the bowel, or your Veress was blocked, or it is kinked somewhere. But still it is going 0, 1, 0, 1, 0, 1, means restricted flow. And then if minimum of the 5 reading is there, within the limit of 3, 4 as you are saying, then there is no problem, you should wait. Because this high flow, this pressure high with the Veress needle always it will show. Why it will show? Due to resistance. And that's why this is, you are correct that sometimes some people they think that they are in wrong and they take it out and then go again. And ultimately they get frustrated with their insufflator, they don't see the insufflator. They don't see the insufflator, they put it, never look at that and just try to find it by other means, by palpating, by knowing, and they ignore these things. But it's a beautiful machine. If you will become friendly with your readings, it gives you immediate information that where the gas is. So now I will give you just a small break, 5 minutes, and after that I am going to discuss the optical part. Any question?